Welcome. Let's dive into the neuroanatomy of the head and neck. Now, we all know it's a notoriously complex topic, but it's one that shows up constantly, both in your clinical practice and on those postgraduate exams. So, in this high-yield explainer, we're going to connect some very distinct clinical problems, everything from a locked jaw to a drooping eyelid, directly to their underlying anatomical pathways. Our goal is to give you a clear, integrated framework that'll help you with rapid diagnosis and, of course, with success on your exams.
So, I want you to think about 3 patient presentations that, on the surface, seem totally unrelated. You've got trismus, or a locked jaw, then you have ptosis, a drooping eyelid, and finally dysphonia, a weak or hoarse voice. What on earth is the common link here? Well, they are all signs of pathology tucked away in the intricate neural wiring of the cervicofacial region. And by the end of this review, you'll see exactly how they all connect.
Okay, here's our game plan for this session. We'll start with a quick overview. Then, around the 45-second mark, we'll tackle our first case, the locked jaw. At about 1.5 minutes in, we'll move on to painful swelling in the parotid region. Next up, around 2:30, we'll get into the critical anatomy of voice and airway. Then, at 3:15, we'll investigate the drooping eyelid, and we'll wrap it all up at about 4:15 with a rapid-fire exam recap and some really useful mnemonics.
All right, Section 1, Clinical Neuroanatomy, an overview. Before we jump into the specific cases, let's just lay down the foundational framework. This is what connects all these seemingly random topics and shows you why thinking about them together is so important.
This table really illustrates our core concept for today. Just take a look. You can see how trismus links directly to the mandibular nerve, cranial nerve V3. See how swelling near the ear can bring the facial, glossopharyngeal, and vagus nerves into play? And voice control, specifically via the cricothyroid muscle, that's a pure vagus nerve function. While a drooping eyelid, or ptosis, can be traced all the way back to the cervical sympathetic chain. The key takeaway here is that these aren't just isolated facts to memorize. They're all part of interconnected systems that we're about to explore in much more detail.
Let's get into our first clinical puzzle, trismus, better known as the locked jaw. This is a condition that's directly tied to the incredibly powerful muscles of mastication. So what is trismus formally? Well, it's defined as a sustained, involuntary spasm of those muscles of mastication, and the result for the patient is an inability to open their mouth, which, as you can imagine, is a pretty distressing and painful experience.
So, what's the mechanism behind this? It all comes down to innervation, in a balance of power. All the muscles of mastication are supplied by the mandibular nerve, CNV3. Now here's the crucial point. Think of it as a tug of war between the muscles that open the jaw and those that close it. And it's not a fair fight. You have one primary opener, the depressor, which is the lateral pterygoid muscle. But you have 3 powerful closers, or elevators, the temporalis, the masseter, and the medial pterygoid. Trismus happens when those powerful elevators completely overpower that single opener. The classic example? Tetanus. That's the textbook lockjaw from masseter spasm. Or think about a parapharyngeal abscess. The local inflammation can irritate the medial pterygoid muscle right next door, causing a reflex spasm. It's all about that imbalance of power.
Okay, on to our next case. This one involves a patient presenting with a painful swelling near the angle of the jaw. This is a very common scenario where a precise understanding of the anatomy is absolutely key to figuring out the differential diagnosis.
When you're assessing this kind of swelling, your differential diagnosis is everything. In acute parotitis, the pain is just excruciating because the parotid gland is wrapped in this tight, unyielding fascia. A deep neck space infection like a parapharyngeal abscess, that's often going to present with that significant trismus we just talked about. But here's a classic clinical pearl for you, referred ear pain, or otalgia. You might have a patient with tonsillitis who only complains of ear pain. Why does that happen? Because the glossopharyngeal nerve, CNI, provides sensory innervation to both the tonsil and the middle ear. The brain gets confused and misinterprets where the pain signal is coming from. The exact same principle applies to the vagus nerve, CNX, which supplies both the larynx and the external ear canal.
Now let's shift gears and talk about the critical surgical anatomy of the larynx. This is an area where knowing your nerves precisely is absolutely paramount for preserving your patient's voice and, in some cases, securing their airway. The cricothyroid muscle is really unique. It's the only intrinsic laryngeal muscle that's innervated by the external laryngeal nerve, which is a branch of the vagus. Every other one is supplied by the recurrent laryngeal nerve. So what does it do? Its job is to rock the thyroid cartilage forward.
This action tenses and lengthens the vocal cords, and that's what raises the pitch of the voice. That's why we call it the tuning fork of the larynx.
This brings us to two of the most high-yield surgical principles in all of head and neck surgery. You have to know these. To protect the external laryngeal nerve, you ligate the superior thyroid artery as close to the thyroid gland as possible. If you injure this nerve, the patient will have a weak, monotone voice. Now, conversely, to protect the recurrent laryngeal nerve, you ligate the inferior thyroid artery away from the gland. An injury here can cause hoarseness or even life-threatening airway compromise. So remember, superior artery, ligate close. Inferior artery, ligate away. These principles are absolutely vital.
And this same anatomy can be life-saving in an emergency. If you need to perform a cricothyrotomy, you start by finding the laryngeal prominence, the Adam's apple. From there, you just slide your finger inferiorly until you feel the next firm ring-like structure. That's the cricoid cartilage. The soft spot, that depression you can feel between those two cartilages, that's your target. That's the cricothyroid membrane.
All right, for our final clinical vignette, let's explore the drooping eyelid. This case is great because it introduces the role of the autonomic nervous system in the head and neck. Horner's syndrome is a classic neurological sign. It's caused by a disruption of the sympathetic nerve supply to one side of the face, and it presents with a very distinct triad of symptoms. First, you get partial ptosis, which is a mild drooping of the upper eyelid. Second, you see miosis, a constricted pupil. And third, you'll find anhidrosis, which is just decreased sweating on that affected side of the face.
Okay, so why is the ptosis only partial in Horner syndrome? This is a really crucial distinction to understand. The eyelid actually has two muscles that lift it. The main workhorse is the levator palpebrae superioris. It's a skeletal muscle and it's innervated by the oculomotor nerve, CN3. If you damage CN3, you get a complete severe ptosis. The eyelid is practically shut. But there's a second, smaller muscle called Mueller's muscle. It's a smooth muscle and it gives just a few millimeters of extra lift. And this muscle is innervated by the sympathetic system. So Horner syndrome only affects Mueller's muscle, which is why you only get a much milder, partial ptosis.
Now, this sympathetic pathway is a 3-neuron chain. The first-order neuron starts up in the hypothalamus and travels all the way down through the brainstem to the upper thoracic spinal cord. A lesion anywhere along this path, like what you might see in a lateral medullary stroke, also known as Wallenberg syndrome, can cause Horner's. The second-order neuron then takes over. It exits the spinal cord around the T1 level and then ascends in the sympathetic chain, running right up the neck. Now, the key clinical point here is its anatomical position. As this nerve passes over the very apex of the lung, it's vulnerable. It can be directly compressed by a Pancoast tumor, which is one of the classic causes of Horner syndrome. Finally, we have the third-order neuron. It leaves the superior cervical ganglion and then piggybacks along the wall of the internal carotid artery, traveling all the way up to the orbit to supply Mueller's muscle. And this explains why something like a dissection of the carotid artery can also present with Horner syndrome. All right, let's bring it all home. Section 6, Exam Recap and Mnemonics. We're going to consolidate all this knowledge with a rapid-fire review of the most high-yield facts just to make sure they really stick for your exams. Okay, you need to commit these anatomical maxims to memory. 1. The mandibular nerve, V3, is the only branch of the trigeminal nerve that has both motor and sensory fibers. 2. The cricothyroid is the only laryngeal muscle supplied by the external laryngeal nerve, not the recurrent. 3. The posterior cricoarytenoid is the sole abductor of the vocal cords. This is the life-saving muscle that opens the airway. And 4. Thyroid swellings move up when you swallow because of their firm attachment to the larynx via the ligament of Berry. And to make these facts even easier to recall, let's use some mnemonics. For the pterygoid muscle functions, just remember lateral opens, medial closes. Simple. For the muscles supplied by CNV3, the mnemonic is MD MyTV. That stands for muscles of mastication, digastric, the anterior belly, mylohyoid, tensor tympani, and tensor veli palatini. And finally, for the cutaneous branches of the cervical plexus, use GLAST. Great auricular, lesser occipital, anterior cutaneous nerve of the neck, supraclavicular, and transverse cervical.
Let's end with one final thought that really connects the dots across different systems. Imagine you identify a Pancoast tumor at the apex of the lung on an imaging study. Based on everything we've just reviewed, what specific questions should you now ask your patient about their eye, their pupil, and even the sweating on their face? The answer, of course, is that you're now actively looking for Horner syndrome. And that, right there, is the essence of applying integrated anatomy to your clinical diagnosis.